Assalamu alaikum. Very good morning. My respected teachers in the chairs, the chairpersons, and the distinguished delegates from home and abroad. I do not have any disclosure, but my only disclosure is I'm a promoter of stress echocardiography. Me and my mentor in the chair, Professor Chowdhury Banerjee, we are promoting the stress echocardiography for more than last 2 decades. We live in an age of coronary angiogram. We sleep with angiogram, we dream with angiogram, we eat angiogram. And we are an angiogram-prone society. But here, I'm going to present you some glimpses of stress echocardiography. I will try to show you the versatility of stress echocardiography. By using those stress echocardiography, you can really save some of your patients from undergoing coronary angiogram, and you're going to do some justice to those patients. So there are some advancement in the stress echocardiography, like the contrast, LV contrast. You can see how nicely the LV can be seen with this contrast echocardiography, and how nicely we can see the viable myocardium. This is a dobutamine stress echo test. Also, there have been some advancement with strain, as has been shown by Professor Dr. Rakesh, and also mentioned by Professor Sabina Hashem. And with the use of strain, if there is increase in the strain with the stress, we know the patient is doing well as regard ischemia. And also there have been, this is an abnormal strain. Also, there are some advancement with myocardial contrast echo. And if you can see here, if I just can show you. Sorry. Just here you can see during the rest period, there was myocardial contrast taken by all the segment of the left ventricle, but during the stress, the inferior wall is lacking. So we know the classical ischemic cascade, which shows that the early stage of ischemia that is manifested by any imaging is perfusion defect. So myocardial contrast echo could have been a good test in stress echo, but still it is not being recommended so far. So there are many advances in horizon. We still do not know whether they are going to find out the clinical home, but still stress tests are going to be the key to the coronary angiogram and going to play a vital role in managing our patients. So there are only few modalities of stress echo, especially we'll confine our discussion in between the pharmacological and the exercise echo. Although we do have the vasodilatory and the pacing, some part in Europe, they perform the vasodilatory echocardiography. As we know, the perfusion in the first stage when the ischemia get caught in those tests. But for all practical purpose, the exercise and the pharmacological stress are there in the table. So these are the physiology that will be very worthy if we can keep in our mind. Dobutamine is definitely it causes contraction, and we can see good contraction with stress echo, but we also have to keep in the mind that the pulse and the blood pressure do not increase up to that extent. We know the way we induce ischemia is the double product of the heart and the blood pressure. But the main purpose of doing a stress for inducing ischemia is really lacking with dobutamine stress echo. What we can see is contraction. But in contrast, if you see the exercise echo, which is very natural and which is very physiological, they really do produce good heart rate and good blood pressure, and eventually they produce good ischemia. So this is our case from our hospital. This patient got admitted 1 month back. 64 years old diabetic patient. He was having myocardial infarction in the past. Also, on echocardiography, he was found to have myocardial infarction along with ischemic cardiomyopathy. So we did a dobutamine stress echo in this patient. Dobutamine stress echo is for those patients who do have reduced ejection fraction. So this was the ideal case for my patient. And you can see very well that if you compare this cavity and this cavity, you can see there is reduction in the size of the cavity during the stress period. And also you can see the viable myocardium that we were looking for. So we were happy with this test. If we send this patient for revascularization, probably there is a possibility that he will get some benefit from revascularization. So stress echo has got many roles to play, not only for looking at the viability, but also for inducible myocardial ischemia for those patients who cannot exercise. But let me tell you, if a patient cannot exercise, then the choice of stress test should be nuclear stress rather than stress echocardiography. But in certain situations, the dobutamine stress echo has got some role. For example, if the patient shows biphasic response in dobutamine stress echo, if we use the myocardial contrast and we can find the microvascular integrity with myocardial contrast echo, if the left ventricular end systolic volume is less than 130, is the end diastolic wall thickness is less than 6 millimeters, all this information give you a very glimpse about the success of revascularization. So the wide range of scope is there from dobutamine stress echo, where we can make some conclusion about the viability of the myocardium and the potential revascularization in those patients. This is a short summary where we can see the response that we can found in dobutamine stress echo, the typical biphasic response with a viable myocardium, the gradual increase in myocardial thickening when there is stunning of the myocardium, and there will be no response at all if the patient do have no viable myocardium. So this is an interesting slide showing a patient when they do have a sizable amount of viable myocardium, at least more than 70% of the viable myocardium is there. Only in that cases, dobutamine stress echo is going to catch the viability. Otherwise, if the viability is less than 70%, it can be detected by the MPI, and dobutamine stress echo will not be able to catch that. But the interesting point is that when we look at this paper, and if we categorically look at the strategy for revascularization, we'll find that if the patient do have the viability of more than 70%, then this patient can directly send for revascularization. So biphasic response that we get in dobutamine stress echo will make us very confident about sending this patient for revascularization, because if there is any hope, there is hope if we do revascularization in those patients. So what are the uses of dobutamine stress echo? We know for years together, we have been using this as preoperative evaluation, since we and my mentor, Professor Banerjee, we work in a multidisciplinary hospital. We get hundreds and thousands of cases for preoperative evaluation, and we have been doing this test, dobutamine stress echo, for years together. And I can tell you, it's an excellent test, and it has got really, as has been described, 100% of negative predictive value. This slide shows another interesting story about dobutamine stress echo. At a time, the patient with a patient with postpartum myopathy. They want to know how they're going to do, what is their prognosis. And particularly in those group of patients, if they show very good contractile reserve in the abutamen stressico, probably they are going to recover. So to tell the prognostic future of a patient with the dilated cardiomyopathy after pregnancy, this test can be useful. There is another important use of the abutamen stressico, which is rather under talked, less talked, unsung story, is its use in left bundle branch block. When a patient do have left bundle branch block, we have the jerky motion in the septum, which really pre-occludes the interpretation of the stress echo. But if you really think about the pathophysiology of left bundle branch block, it is a fan-shaped bundle which just do not only involve the septum, but it is supposed to involve the whole of the anterior surface of the left ventricle. So in patient with LBBB, if you do the abutamen stressico and if you find there is a good motion in other territory other than septum, has good contraction, then you know you are dealing with a normal coronary artery, and only there will be some abnormality in the septum. So LBBB is another good area where we can do this abutamen stressico. As we know, the stress spect is not good enough for LBBB. Particularly in this slide, I'm showing you what is the difference between abutamen stressico and exercisico. If you look at the picture, at the top, you can see that despite ischemia, in the abutamen stressico, the LV cavity is smaller, while in stressico, the LV cavity during stress is not that small. Why? Because we know the abutamen causes much more contraction. This is one of the limitations why we miss the positive test in the abutamen stressico. Number one, we cannot really evoke that much of ischemia. Number one. Number two, if we evoke the ischemia, the size of the left ventricle becomes smaller, so that we cannot make really that good interpretation. In that respect, this exercisico is much superior if we really consider about the sensitivity of stress test. So here we go to our second case, 65 years old male. He was a retired principal of a medical college, hypertensive. He was complaining of exertional chest discomfort. At this age, we know he is having some form of coronary artery disease in his heart. But are we going to send them to the coronary angiogram? No, probably no. Because we have got some tests to tell them the medical therapy is going to do equally good if they have gone equally good to like that of revascularization, maybe even better. So what we did, we did a treadmill exercisico. I want to show this slide more and more because in this part of the world, we really do not prescribe this test much. But if you do have a treadmill and if you have an echocardiography machine, then why we are not doing this test all over the country? It is really useful, quite useful. As you can see, particularly in this patient, he was having a normal stress echocardiography. You can well appreciate the size of the left ventricle has been reduced during the exercise. And eventually, if you look at the sensitivity and specificity, it's as good, even better than the SPECT. If you look at its compatibility with bicycle ergometer, then also it is equally good. The specificity is better, and the long-term prognosis is going to be as good as that of a normal person. And if you compare the long-term survival of a patient with negative stress echo and a negative SPECT, they are going to have similar sort of survival. And this slide should be more appealing because we can see if you just look at the middle two column, you can see that the revascularization and the optimum medical therapy offers equal benefit, even if the patient do have some form of motion abnormality. But if the score is less than, the index is less than 1.7. One more prognostic factor that we can get from this exercise echo is the left ventricular end systolic size. If the size is less, then again it is going to have a good prognosis. So we have got so many parameters. The negativity, the wall motion score, the LV systolic diameter, and if you look at this chart, also the information that we get from the exercise test treadmill ETT, which has been very gold standard to show a good prognosis over years and years, and we have got robust of evidence in favor that the patient doing well with treadmill, they really do well in their life. So with all these prognostic good factors, I have suggested this retired principal to undergo optimum medical therapy, and I think the decision was very clear on my part. So this is a chart showing the difference between the survival in patient having positive and negative stress echo. These are the few points that we can take into account to make a comment about the long-term prognosis of a patient undergoing stress echo. So this is our last case. He was a 58 years old gentleman. He was having a CABG and he was complaining of chest pain. So particularly in this patient, after seeing the patient have had the pericardiectomy, and his echo is ought to show some sort of jerky motion in the septum, we decided to go for bicycle ergometer in this patient. I'm grateful to my mentor, Professor Chowdhury Banerjee. He arranged this bicycle ergometer in our Bangabandhu Sheikh Mujib Medical University. I'm extremely grateful to Dr. Osmani. He's running the show, and also I'm grateful to Dr. Mustasir, Dr. Yari Mahbub, and Dr. Rasul Amin. Those are the people who really have run the dobutamine stress echo in our university. So particularly in this patient, we had some problem in the LAD territory. So if you look at the chart, during bicycle ergometer, heart rate does not increase, but blood pressure increases. But if you consider the product of the blood pressure and the pulse, the bicycle ergometer produces more stress than the treadmill. So bicycle is the best test probably so far the stress echo is concerned. And on the top of that, we can have a numerous data as regard the right ventricular function, data regarding the mitral regurgitation, newly formed mitral regurgitation always indicates severe ischemia. We can have the diastolic dysfunction estimation. We can have estimation assessment about the valvular diseases and so on things. And again, let me remind you about the ischemic cascade. And we can see that the diastolic function occurs earlier than the systolic function. So stress diastolic function going to reveal the ischemia earlier than the wall motion abnormality itself. This is a study, I think it is one of the very important studies which was done with a patient who were having unexplained shortness of breath, unexplained shortness of breath. And we can see that in those patients, a significant causes could be revealed because some of them had ischemia. Probably that was the main purpose of doing the stress test. But occult pulmonary hypertension and the diastolic dysfunction could be well revealed, and the patient with unexplained chronic shortness of breath are a very good candidate for bicycle ergometer stress echo. As I said, valvular disease, when we get disparity between the symptom and the severity, it is an excellent test. We can do the Doppler studies and other study to reach in a conclusion. So ladies and gentlemen, please learn to live with stress echocardiography. Please try to love stress echocardiography. If you really can use the different modalities of stress echocardiography, you really can give good guidance to your patient. Don't sleep, don't eat, and don't dream with coronary angiogram alone. Thank you very much for the patient hearing.